All right. Good afternoon, everyone, and thank you for taking the time to join us today for our third webinar for the Measure Development Education Outreach for Specialty Societies and Patient Advocacy Groups. My name is Nicole Brennan, and I am with Battelle, and today's webinar is on our Introduction to Electronic Clinical Quality Measures, and our presenter will be Kathy Lesh, also from Battelle, and one of our research leaders in the area of electronic clinical quality measures. So let's just review real quick here for a minute what we're trying to do. This will be an ongoing webinar series over the course of the next several months, working with you to understand the measure development cycle and process, learn about the tools and techniques that we have available through the measure management system, and then also to give you an opportunity to work with CMS to introduce any measure concepts that you have or that you are working on currently or have worked on in the past that you think would be of value to CMS's programs. I see that there is already a question in the box about downloading slides to take notes on them. Unfortunately for this one, we did not provide the slides before the webinar, but we will post them on our measurement management website after the presentation, and we'll be sending out notifications to everyone when that happens. We are working right now to make sure to get the PowerPoints up there soon, and then they will be swiftly followed by the actual recordings for the webinar series, which we need to do a couple of things to make sure that they are fully 508 compliant to get up on the website, but we will work faster to get up the actual webinar slides for you as well. And also just feel free to use that Q&A box throughout the webinar to ask questions if you like, or if you would like us to call on you for a question, please just put in your name and your agency and we can call on you that way as well. We will at some point be unmuting the lines throughout the presentation so that we can have an active dialogue amongst ourselves. So please remember to put your phone on mute. And if you need to take another call, to just go ahead and hang up on this one and then call us back, when you have the chance or if you can. All right, so with that, I will go ahead and turn it over to Kathy Lesh to do the Introduction to Electronic Clinical Quality Measures. Kathy?
Hi, Nicole. Thank you. And thank you, everyone, for taking the time to join us today. This presentation is meant to be a high-level overview of electronic clinical quality measures. We anticipate having monthly eCQM presentations on the second Wednesdays of the month at 2 p.m. Eastern. Right now we have a demonstration of the Electronic Clinical Quality Improvement Resource Center scheduled for January 11th. We're looking to do other potential topics of the different standards that are involved, the terminology, and some of the other tools that are used with electronic clinical quality measures. So, prior to the introduction of electronic clinical quality measures, data collection for most measures was either via chart abstraction and submitted by manual entry through one of a variety of methods or portals, or claims. And here's just a listing of some of the different networks and ways that you've been submitting measure information over the years. Now, with chart abstracted data, you have a lot more flexibility in that the data may reside in multiple places in a patient record. The abstractor can manually flip through the record looking for the data. If there are discrepancies in the data, the abstractor can make a decision as to which data point is accurate. So, we enter the eCQMs. eCQMs became part of our environment through the HITECH Act, which was part of the American Recovery and Reinvestment Act of 2009. And if you look through this, we had 113 existing National Quality Forum endorsed measures were retooled into eCQMs, 29 for hospitals or acute care and 64 for eligible professionals. CMS is no longer retooling measures, and I'll talk a little bit more about that on the next slide or two. Next. So in the early parts of the EHR incentive programs, which is where the eCQMs were sitting initially, CMS was allowing for attestation of quality measures data. And what that means is that the provider attests to the fact that the numerator and denominator of their measure came from an EHR. And there were some problems initially with the first group of quality measures, eCQMs. There was a 100% failure rate. That's because the specifications were not too clear. Now, there are more programs that CMS is having adopt eCQMs. And for example, calendar year 2016 was the first time the hospital inpatient quality reporting program required eCQM submission, not just attestation, but actual submission of the quality measure. So exactly what is an eCQM, or electronic clinical quality measure? Well, you may have also heard the term e-measure, and that was the initial term that was used coming out of the National Quality Forum. The e-measure is the actual health quality measure format. The eCQM is the HQMF, which is an XML format, and the human readable HTML, so that you can see it in a web browser, and the value sets. And I'm going to talk a little bit about each of those things a little bit more. The term e-measure is still used by some organizations for the whole package. And I'll give you more on the value sets in just a minute. So I mentioned previously retooled. And CMS is no longer retooling measures. They are now respecifying measures. And a respecified measure is taking an existing quality measure, whether it's from an existing chart abstracted or claims measure, and starting from scratch, basically, and using the measure authoring tool to create the eCQM. The retooled measures were not done this way. For one, the measure authoring tool didn't exist at that point in time. And then there's also de novo measures, which are brand new, no existing measure. So the respecified is using evidence that led to the measures originally developed from other sources, and therefore they may actually include different data elements than the original quality measure created based on the same evidence. An example of a respecified measure is alcohol use screening. And then the de novo measure, an example for one, there is one on the measure under development list, which is a very long name about antipsychotic medications. And I won't read the whole thing for you. But the idea is that the general concept the concept of a de novo can relate to an existing measure, but it really takes it a completely different direction. Opportunity for questions again.
And Kathy, a question has come in through the question and answer box. Do you know how many providers are incorporating eCQM/NQF endorsed measures into their EHR, and what percentage?
I don't have the exact numbers, but anybody who's been participating in the EHR incentive program, well, let me back up. All certified electronic health record technology must have electronic clinical quality measures built into it. So if someone has a certified EHR, the quality measures are there. Getting a lot of feedback, probably because somebody's not muted. Through the EHR incentives program, if you want to get credit for being a user, a meaningful user, you do have to submit eCQMs. And as I said before, initially it was only had to be attestation. but now, like PQRS and CPC, I believe, are still on attestation, but there is an option for PQRS to actually submit the QRDA, the quality measures themselves. I see another question about, will this program remain when the new administration takes office? Well, eCQMs are not restricted to just one program. They're in a multitude of programs now. So I would sincerely doubt that they would go away in all of the programs. Were there other questions? Okay, we can go on. So what are the differences between clinical quality measures and eCQMs? Well, eCQMs require the use of standards and tools. Now, other types of measures can actually use these same tools and standards, and I'll talk more about standards and tools in a minute. For the chart-abstracted measures, a human can think through the logic and adjust the terminology on the fly. With eCQMs, the data abstraction or extraction, in this case, from the electronic health record will follow the logic statements in the HQMF, which you've heard before, the health quality measure format, even if it doesn't make sense. And it will only look for the data where it's told to look. Now, the HQMF does not say where in the EHR that data should be. So each vendor interprets the logic, which unfortunately means there can be different interpretations between vendors. Now, looking at logic, in the blueprint, logic is the criteria used to define a quality measure and its key components. And currently, the eCQMs use the quality data model to express both the data desired and the logic, or the relationships between the data elements and the mathematical calculations. There are arguments for only using data collected in a structured field. What that means is there is a field such as a laboratory test with an associated standard terminology. In this particular case, it would be LOINC, in which to capture the data, as opposed to a text field where the data must be extracted using natural language processing or something similar. Additionally, there are other arguments for collecting data elements external to the EHR or new data. So now, some of the standards. I've mentioned the quality data model. What that is an information model that clearly defines the concepts used in quality measures and clinical care, and it's intended to enable the automation of electronic health record use. It provides a way to describe the clinical concepts in the standardized format so the individuals, providers, researchers, measure developers, monitoring clinical performance and outcomes can clearly and concisely communicate necessary information. The QDM describes information so that the EHR and other clinical electronic systems can ideally consistently interpret and easily locate the data required. Now, that may sound a little bit different than what I just said on the last one. There's a goal that we're trying to get to, that while we have the standards and the data elements and the standard terminology, we still have a little ways to go to make sure that the data collected is consistent across different vendor and data sources. And I say the QDM currently includes the measure logic. The clinical quality language is a fairly new health level standard logic language that's undergoing testing with electronic clinical quality measures. The intent is for the QDM, the quality data model, to continue to be the grammar with the clinical quality language as the logic. Clinical quality clinical quality language has been integrated into the measure authoring tool in a development environment and is anticipated to go into production environment sometime in 2017 fall. It's being tested right now. So for more information on clinical quality measure, you can go to the Resource Center, and there is a page for the CQL. And then we also have value sets. And the quality data model is linked to the Value Set Authority Center, which is where measure developers create their value sets. It's linked using the measure authoring tool. This graphic comes out of the quality data model. The latest version is 4.3, and you can get actually all versions of the quality data model on the Resource Center. Now, the quality data model can be used for non-eCQMs. It's a good way to organize measure specifications, and there is a QDM user group that meets once a month, and anybody is welcome to participate in that group. Now, a little bit more about standard terminologies and value sets. Now, most measures already have standard terminologies that they use, mostly ICD-10 now, previously ICD-9 and CPT codes, which are the common procedural terminology from the AMA. And they're still used to define clinical concepts in quality measures. But when the Health Information Technology Standards Committee made recommendations for which standard terminology should be used for the different data elements, they went with terminology such as SNOMED CT, which is a reference terminology that covers a lot of different concepts. RX norm is out of the National Library of Medicine, and it's all the drugs. And then LOINC, which is laboratory tests and other kind of observations. So ICD and CPT were defined by this group to be transitional terminologies with the ultimate goal of moving away from ICD and CPT in the future. However, that's not yet happened, and measure developers should select the best terminology or terminologies for the concept in use. Now, if you're doing anything that uses a claims-based measure, you're definitely going to want to use ICD-10. Now, if you look at some of the specifications of the existing measures, you will see that ICD-9 remains in some of the measures. It needs to stay there for historical look back, because people are not going back into their records and changing the codes on historical data. Now, there are standard terminologies associated with each data element. For example, LOINC is to be used for observations, and SNOMED CT for observation values. RX norm is used for medications, and there is an HL7 standard coset called CVX that's used for clinical vaccines administered. And although an electronic clinical quality measure may have the same name, denominator, and numerator as another non-eCQM, the terminology requirements may lead to differences in the populations. This has been an industry concern that the results of the eCQMs and their same name non-eCQMs are not comparable. Okay, I've mentioned the measure authoring tool, the MAT, and here's a little bit more information on it. It's a web-based tool that allows measure developers to author eCQMs using the quality data model. The tool provides the capability to express complex measure logic and export these measures in several formats, including a human readable document that's an HTML format and the fundamental basic HQMF document. And the HQMF document is what's integrated with the EHRs. The data expressed in the tool by the users serves as the input to transform the process, which ultimately supports the defined export files. The MAT allows measure developers to create a measure in HQMF without having to know the technicalities of HQMF. And the Value Set Authority Center can be accessed from the MAT with a valid UMLS license, and I'll talk a little bit more about that. So here's the Value Set Authority Center. It is run by the National Library of Medicine, and all the value sets that are used in the current eCQMs are found in the VSAC. The VSAC is also used for non-eCQM purposes. They're using it for clinical decision support terminologies, as an example. any measure developer can use, and they're encouraged to use the VSAC to develop their value sets. The use of the VSAC is free with a UMLS license, and the UMLS is the Unified Medical Language System. And that is a compilation of almost 200 different terminologies linking concept names between terminologies. And you don't need to know all of the terminologies in the UMLS. As I mentioned earlier, you're going to focus your efforts on SNOMED, LOINC, RxNorm, ICD. Well, the previous slides addressed primarily eCQM development, but that's only one side of the coin. And just as there are multiple ways to capture quality data, there are multiple formats for actually reporting quality data to CMS. And here are just some of the examples. eCQMs are submitted using QRDA, or the Quality Reporting Document Architecture. And currently, hospitals can only submit in QRDA 1, which is patient-level data. Eligible professionals can submit eCQMs in either QRDA 1 or QRDA 3. QRDA 3 is aggregated patient data. And providers can submit the QRDA themselves or through a data submission vendor. There are some tools for testing eCQMs. Bonnie is a tool that's used on the measure development side for testing measure logic. It validates the logic and ensures that the logic matches the measure's intent. Bonnie uses patient scenarios to represent each logic component of the measure specification, such as the initial patient population, denominator, numerator, and exclusions. Health IT developers and implementers may also use Bonnie to evaluate measure implementation into their systems. Cypress is the tool that the EHR vendors use to certify to electronic clinical quality measures. So Cypress enables testing of the EHR's ability to accurately calculate eCQMs. And it is the official testing tool for the 2014 EHR certification program by the Office of the National Coordinator for Health IT, otherwise known as ONC. And there are pre-submission QRD validation tools. PSVA, the pre-submission validation application, and the SEVT, or the Submission Engine Validation Tool. Both of these are accessible from the password protection portion of the QualityNet portal. A PSVA is a downloadable tool that operates on the user system and allows hospital quality reporting submitters to catch and correct errors prior to submission of data to CMS. The application provides validation feedback while within the submitter system and allows valid files to be separated and submitted while invalid files are identified for error correction. SEVT is a testing tool which allows for the format validation of data files against the most current published data submission specifications. The SEVT provides registered users with an interface on the current PQRS, or Physician Quality Reporting System portal, to submit and authenticate a data file. Now, I see a lot of questions came up because this is a very intense kind of stuff if you're not used to some of the terminology. Let me go up to some of the questions. Under the eCQM, would there be no option for manual abstraction, as it looks like the eCQM is looking at structured data only? Well, there's no requirement that an eCQM looks at structured data only. That's the focus, but there is the capability, and this is up to the individual end user, to use something like natural language processing to look at text and pull data out of narrative text. There are some hazards with that, which you have less of the hazard using structured data. And next question, can a provider facility hand review extraction before submitting, or is it required that the data be submitted directly from the EHR? no, you can definitely review the data before you submit it. It's just that the requirement that the data must come out of the EHR. You mentioned that variations in interpretation among EHR vendors. Has CMS done any analysis of variations reported in performance depending on the EHR's provider, the provider's EHR? I have not seen any. That does not necessarily mean it hasn't been done.
And Kathy, Kristen Borowski from CMS is on the line too. I'm not sure if she's unmuted at the moment. We'll try and get her unmuted here in a little bit so that she can also help address any CMS specific questions. So we can wrap back around to that question at the end of your presentation as well.
Sure. We have 5 different EHRs in our ambulatory setting, and each EHR calculates the data separately, differently, which is frustrating. Will the EHR's eCQMs be certified in a standard way? Well, they go through Cypress in order to be a certified EHR technology. But what Cypress can't do is all the different methods or different ways or different directions that a particular data element can sit in an EHR. Right now we don't have a standard EHR database, which if we did, that would make life a lot easier. So while the eCQM is certified, yeah, you still have the potential, if it's a different vendor, for different interpretations of the logic. Hopefully, as we make more improvements on the eCQMs over time, that's one of the issues that we will deal with. Reworded question: in using eCQMs for incentives, can a provider facility hand review the data extraction of the eCQM before submitting? Yes. If the value set is not current in the VSAC, what due diligence is required to create one? Well, if you're a measure developer, you are responsible for creating the value set. And as being the creator of it, you're responsible for the maintenance and upgrades of that. Now, National Library of Medicine does help out with that because there are regular updates to the different terminologies, and some of the concepts may be retired or new concepts may be added to a terminology. And they actually provide reports on that kind of additions and deletions. And currently, all of the eCQMs are reviewed on an annual basis, and the measure developer is responsible for looking at the value sets as part of that. It's very similar to any other kind of measure that undergoes an annual review, which is what National Quality Forum requires, and they're looking at the different code sets and code systems. Were there any other questions? Okay. We go to the next slide. So, for developers, we got now in the future. So we've got eCQMs that are a part of several different quality reporting programs, and there is the expectation that more will be added to programs in the future. The EHR incentive program is included in MIPS as one of the 4 criteria, and part of that is quality measurement, and quality measurement is its own part of MIPS. So we can definitely expect to see more eCQMs in the future. So for developers, when it comes to eCQM development, the steps are not that much different than for developing other electronic clinical, or excuse me, for developing other quality measures. In the new version of the blueprint that's under development now, which is version 13, the eCQM specific chapter is going away, and all of the eCQM specific information is being incorporated into the other chapters as needed. But a lot of the information that was current, that was in the previous versions, section on eCQMs is going away because it's duplicative of what's in the main part of the blueprint, because there's very little difference in the actual process to develop a measure. So measure developers need to be familiar with the data that are available in an EHR. And you also should be looking at what is the workflow, because ideally you want the data captured in the normal flow of doing care. You don't want people to have to make a special effort to do some documentation just for a quality measure. And that's with any kind of quality measure, not just an eCQM. Now, the measure authoring tool allows the measure developer to create an HQMF document without knowing the technical aspects of the HL7 standard. So you don't need to be a technical guru to do this. And the main differences are the requirement to use standards. And even in a regular measure, there is some measure logic, but with an eCQM, you actually have to write the logic a little bit clearer, and then your data source is different. So EHR vendors should be working with eCQM developers to iteratively test eCQMs. One big question is, are the data elements feasible? And what about the standard terminologies? What has happened historically is that a lot of the EHRs have their own internal, or even like a hospital will have their own internal terminology. So what has to happen is they map the internal terminology to the standard terminologies. And that requires judgment and interpretation, which can run into inconsistencies. So actually having the standard terminologies integrated into the EHR is ideal. So for clinicians, ideally the data needed for eCQM should be captured in the course of providing care, as I said. And many of the eCQMs and the EHRs are not quite there yet, and the clinicians have had to adapt their workflow to meet the data capture needs. But clinicians should also be working with eCQM developers to help them understand the workflow. And we're looking for ways to get frontline clinicians involved in measure development. So we've got these new kind of measures. What are some of the potential or actual impacts to the quality reporting programs? Well, manual data extraction is labor-intensive and expensive. Electronic extraction should reduce expenses and return the clinician time back to patient care. That's one of the ultimate goals. With respect to the amount of data, there is no sampling with eCQMs, as the data for all the patients in the denominator are submitted, which is different than most of your chart abstracted measures where you can sample. And there are other things. I mean, data validation is an issue. The hospital inpatient quality reporting program has an eCQM validation program set up, and I would guess that other data validation programs will pop up over time. So here's some of the references. So the eCQI Resource Center, which is the Electronic Clinical Quality Improvement Resource Center, it's the one-stop shop for your most current resources to support electronic clinical quality improvement. The Resource Center provides technical resources, and I encourage you to check it out and offer suggestions for improvement of this site, and there is the link for it. And I mentioned the MAT, the measure authoring tool. You can, anybody can get a license for the MAT. There's no cost to it. They just require some information that you submit. Same thing with the VSAC. You need a license, but it's a free license. They just require you provide some information. Now, the National Quality Forum, initially they didn't have a separate measure number for eCQMs. They had the same one, but they're now giving the eCQMs a separate NQF number. For example, on the eligible hospital measure anticoagulation therapy for atrial fib flutter, the eCQM number is 2832, but it's still associated with the original NQF number of 0435. And as I said, we plan on doing an eCQI Resource Center demonstration on the 11th of January. But if you happen to be going to the CMS Quality Conference next week, we will be doing a demonstration on Wednesday at 4 in the Grand Ballroom number 2. And at the bottom there you have JIRA. JIRA is an issues tracking application that's licensed by the Office of the National Coordinator. And all of the technical questions about eCQMs should go to JIRA. Again, to submit a question to JIRA, you need to have an account. It's free. And when you go into JIRA, there's many different projects. And if any of you have submitted measures for measures under consideration list, it's the same tool. It's just that there's different projects. So if you have questions about the eCQMs, you go to the CQM project. If you have questions about QRDA, you go to the QRDA project, and so on and so forth. Now, the previous slide listed technical kind of information. Program-specific information is not found on the Resource Center. You need to go to the program-specific pages for policy and program-specific answers. So here's how it is broken down for IQR measures, for the EH Incentive Program, PQRS, and then there's the new QPP site. So I have put together a couple of discussion questions. And are there eCQMs available for your practice area? If not, what are those practice areas that are lacking? And then to follow on, what support do you need to help develop eCQMs?
Okay, all of the lines are unmuting right now, so if you have a response, please do feel free to speak up. Also, you can use the Q&A box for any questions.
And this is Kristen Barassi from CMS. I just wanted to circle back around to the question about the analysis of variations in reported performance depending on the provider's EHR. I don't think we have anything like that, but if we do, we will definitely send something out, but don't have anything. So,
thank you, Kristen. So the second question, based on some of the questions that came in, I believe that some of you have experienced issues with the eCQM. How about positive experiences? No positive experiences. And I see someone has mentioned that behavioral medicine and neurosurgery don't have eCQMs. Okay, and the experiences with the eCQMs have not been positive, time-consuming and frustrating. Randy, would you be willing to share your frustrations with someone at some point in time?
Yeah, I certainly would be able to, yeah.
Okay, because we're always looking for ways to make things better.
You know, the other experience that we've had is that we have 5 different ambulatory EHRs, and we have 3 different inpatient EHRs that we deal with. And each one of them is certified for different quality measures. And some of them are registries, and some of them don't have registries associated with them. And so an EHR vendor will say, "Hey, we have 50 that we've certified, or 26 that we've certified, or 40 that we've certified, and that's great. Only we have about 20 different specialty and subspecialty practices, and we cannot find any that are certified, that can be sent through CMS." And so the number just gets so limited as far as what we can select from, what different EHR vendors have available. And so that is just extremely frustrating.
Okay.
I think another
Anyone
issue.
Else?
Yeah, can you hear me?
Yes, go ahead.
Okay. I think one of the issues you're going to face, or we're all going to face next year under MIPS, is that while there may be a few eCQMs for certain specialties, and they were reported under PQRS and meaningful use electronically, there may not be 6. And since you have to report all quality measures using the same submission method, it basically eliminates the potential of reporting electronically if you're concerned about reporting directly relevant measures and therefore producing good results. Where I'm with an EHR vendor, and this is a big problem for us now in advising our clients what to do next year, because while they could get away with reporting unrelated measures under PQRS because the requirement was just to report and do as well as you could do, now it's a competitive game where performance matters, and so to report a non-directly relevant measure may not be a good idea. It may not matter so much in 17, but going forward it's going to matter. So I'm curious as to what's going to happen to the eCQMs, because I can't imagine that there will ever be 6 for each specialty, that are available and relevant for providers. I think this is a big issue, and no one seems to be concerned about it except for me.
Oh, I think there's lots of people that are concerned about that.
Okay. Well, I made a comment about that when I submitted my comments to the proposed macro rule, and I said, how about, splitting up the option, let people report some, electronically to keep up that process, and the others in another fashion. And I don't think the comment even got a response.
Well, all comments have to get a response. It's just a matter of whether it's individually or if it's in a group.
No, I know, but I pretty much read through that rule, all 2,300 pages, 2,400 pages, and I didn't see it. But that's not the point. The point is it's an issue.
Okay. Yes, it is an issue.
The other issue,
I don't know what CMS is advising people to do next year, but, I can't in good faith advise people to report electronically, even though we're an EHR vendor and I want them to. And we've put a lot of effort and money into creating our QRDA submission process and making it user-friendly and successful.
I think someone else had a question.
Yeah, this is Randy again. We have quite a few registries. I'll take an example, the AQUA registry for urology. And there's a lot of measures that they have gone after CMS to get certified for, only there's no benchmarking data that's out there. So we can submit them either manually or we can submit them electronically, but we have no benchmark data to know whether we're doing good or bad. Other than what's in the registry, we have no idea if that data is good or bad, and that makes it frustrating, especially from the eCQM, because not very many people are submitting them electronically.
Okay. Thank you for sharing that. Other questions or comments?
Comment on the last speaker for the 6 that need to be up and running with all different domains. I think a couple of things on that. I think that's why the grace period of 2017 performance year was given. But I'm from the long-term care post-acute site where we are still trying to struggle, and you hear me speak every single time to have valid and relevant physician measures, and so my taking is that with Battelle and with other MD the measure development resources, that this is the forum where specialty societies come together and start talking about using the next several months to come up with a strategy and develop the wholesome 6 measure set, preferably all electronic. So for the following year, those can be used by their members and physicians. That makes sense. But also, again, going back to what I say every single time, is how is CMS and you guys going to help folks that absolutely have no resources to start working? I mean, we have the people, volunteer members, but getting the technical experts and getting all the specialty workers that you need to get measures authored and approved, you still need a lot of resources. So I think several of us are waiting to hear how we're going to get supported.
Hi, thank you for that question, and it's a great one and one that we've been talking about a lot and is a topic that has come up throughout the course of the webinars and through conversations that I've been having with other specialty societies and patient advocacy groups, and one that I know that CMS is hearing. So We will likely do a webinar that addresses that topic specifically. We will be doing a webinar in the very near future about how to apply for CMS grants for this type of work. So more to come on this topic specifically. I think it's very important, and I do appreciate you bringing it up again, and one that I know a lot of us are interested to dive deeper into. Kathy, I think I had another question here that we may not have gotten to. For quality measures for MIPS, will eCQMs be provided for all measures?
I don't know the answer to that question. If I had to guess, I would say no.
Okay, and we can add that also to our frequently asked questions document that we're putting together through the webinars, and try and get that answer through CMS and post it up onto our website here in the near future. Kathy, another one. So the possibility exists. Sorry, go ahead.
No, it's just the ways that you can report on that, the measures was already published. So all the measures are there published. You have the way to report for that measure already there. So all the ones that are available as eCQMs, you have that there in the rules already.
Right. I think the question was whether they were going to create eCQMs for the ones that aren't currently eCQMs. And let me just say right now that not every measure should be an eCQM. Some of them are just not meant to be that way. So I would sincerely doubt that they're going to do a lot of respecifying because that's time intensive and resource intensive. But we will definitely follow up on that on our Q&A.
Kathy, for clarification, we had a question that's asked, so the possibility exists that a quality measure used 1 year will not be approved for the next?
That's true. I mean, every year there are, CMS puts out new rules, whether it's the PFS, the OPPS, IPPS, and the measures vary. But normally, they have good reasons for withdrawing a measure from an option, and usually it's because it's no longer valid. The practice has changed, or the performance on the measure has topped out.
Okay, and I'm going to ask another question. Allison, feel free to speak up if I don't ask this quite right. But who would need to develop a measure? Are most hospitals/providers submitting measures already developed?
I'm sorry, Nicole, can you repeat that?
Sure. So who would need to develop measures? Are most hospitals/providers submitting measures already developed? And Allison, if you're on the line, elaborate on that.
Allison. So just a brief, my background is we regulate hospitals in Maryland, and so I'm just trying to understand eCQMs and what our hospitals and other hospitals are doing. And I'm not, this isn't my area, so when we keep talking about measure development, is that really for areas where there aren't yet eCQMs, or are most people going with what is already out there?
Well, right now, the measures that are going to be submitted are already out there. I believe the goal is to develop more measures over the years, especially for the different specialty societies, because there are such gaps.
Okay. I think I just get confused when during the discussion it's sort of about development, and I'm looking for the more what are people doing. So I just wanted to make sure I was not missing something, that people were needing to develop them as part of this process. So thank you.
Other questions and comments?
Great. So it looks like we're getting towards the end of our hour here. I just want to go ahead and highlight again the Spotlight opportunity, which is an opportunity for you if you are developing quality measures or have quality measure concepts in mind to let us know, and we can set up a time for you to discuss those ideas or your measures with CMS. And you may email us at mmssupport@battelle.org to let us know that you have interest in that, and we will follow up with you. Upcoming webinars in the future, also feel free to speak up if you have suggestions for topics. Email email us if you have topics. We will be doing a webinar coming up specifically around the MAP process. That will be in January. Other topics coming up very soon around stakeholder engagement as well. So please, again, we want to structure this series around your needs. So if you have specific topics, email us and let us know. And just in closing, thank you again for joining us in this series. And here is the contact information again for MMS support as well as for Kristen and Ted at CMS. All right, thank you so much, everyone, for a great webinar and great discussion, and we will see you at the end of the month. Thanks. Bye.